and welcome everybody. So good to see everybody. And I want to thank you for being here today. I know everybody's time is at a premium. So if you're here, then you've made the choice that this is an issue that is really important. And I couldn't agree more with you. We'll take a few more seconds to answer the first poll. And then Austin, if you would bring up the results. So interestingly, abortion and reproductive rights in this group is front and center, but so is healthcare, voting rights, the economy, and gun rights. And so that's very telling, if you will. But I would also say that if you vote for issues that affect women's health, and you'll hear about those today, you will make an impact on most of those issues that you've said were important to you. I'd also like to see if we could get a poll, how many people have voted yet? So if you could bring up that poll and we'll take the temperature. And it's so great to see everybody from so many parts of the country. So 2/3 of you still have not voted. I'm hoping that by November 8th, that will be 0 that have not voted. And that, again, this webinar will serve to inspire you. So as you may know, I host a podcast, Beyond the Paper Gown, which focuses on women's health issues and not just the medical conditions we experience, but how we as women experience the health system and the other factors that impact on our health and well-being. The common thread is that all of these factors are impacted by policy and legislation, and those policies are created and enacted by those we elect. So what better time to talk about these issues than on the cusp of the upcoming election? 13 days and counting. You know, I'm so grateful for my partners in bringing this webinar to you. They not only offered to join me when I shared this idea with them, but they made this a better event by their input and participation. So a special thank you to Liz Powell, founder of G2G Consulting, who advocates for women's health policy, among other things, Linda Goler Blount, President and CEO of the Black Women's Health Imperative, the only national organization dedicated to Black women's health, and the Off Script Health Network, of which we are a proud part of, whose mission is to improve health outcomes by engaging consumers through the audio medium. I also want to thank Austin Talley, who you've met, our webinar producer today, and my gown team, Patrick Shambayati, our audio engineer, along with a very special thank you to our associate producer, who is so much more, Kyla McMillian. Last but not least, I want to thank the panelists who are joining us today. Each one of them should get at minimum an hour to talk about their areas of expertise. But our goal was to provide a broad view in a small amount of time to impress on you the many ways that policy impacts women's health. So I sincerely thank them for being willing to be a part of this powerful ensemble to do so. So let me tell you what to expect today. We're going to talk about 3 general areas where policy impacts women's health. We're going to try to leave some time at the end of each panel for questions. Our last panel will be focused on action, what you need to do to make your vote count, and what to do after the election to advocate for the issues you feel are important. We'll also be sharing a link with you to join our discussion session after the webinar, where my fellow podcast hosts, Melissa Boudreau of The Cycle and Claire O'Brien of Dabble & Co., along with our panelists, will moderate. Even if you didn't sign up, you're welcome to join us by just clicking on the link after the webinar. And one final note, we've seen in real time and in Technicolor, shows you how old I am, the effect of legislation with respect to abortion rights. The impact of the Dobbs decision goes well beyond abortion, and we had another webinar in July called Aftershocks, where we addressed that broad impact. Today, we're going to talk about the Dobbs decision, but we're going to address many more issues in this very short period of time. So if you want to learn more, please check out our Aftershocks webinar and podcast at beyondthepapergown.com. It's now my pleasure to bring on our first panel. We have Dr. Karen Joynt Maddox, who is an associate professor at Washington University School of Medicine, Dr. Nicole Scott, who is head of the residency program in OBGYN at Indiana University, and Dr. Kimberly Templeton, past president of the American Medical Women's Association and an orthopedist at the University of Kansas. Welcome, everybody, and thank you so much for being here. Nicole, we are going to just address the elephant in the room. The Dobbs, you were front and center with respect to a few months ago, you and your colleagues, with respect to the 10-year-old who had to cross state lines in order to have an abortion. How has the state legislation changed, if anything, for you guys? And how has that affected what you're doing with your OBGYN residency training program?
This is a great question. Indiana was one of the first states to pass restrictive legislation in a post-Dobbs world. Our governor called a special session, which is pretty atypical, and we had some more restrictive laws passed. As the residency program director, this directly impacts what my residents do and the education we provide. ACGME, which is the Accreditation Council for Graduate Medical Education, dictates kind of what is required for an accredited training program, and abortion training is part of that. And so if I have restrictions from my state legislator or nationally, that affects how I can train my residents, and furthermore, kind of the accreditation of my residency program. And then obviously the big picture is kind of the quality and the exposure of the future OBGYNs of our country.
Talk a little bit more. How does that impact on what you can and can't train, and how you're now training your residents, and how does that impact on the skills that they bring to clinical practice?
Sure. So with restrictions, in some states, it's a complete restriction without exceptions. We do have some exceptions in our state, but it dramatically decreases the number of termination procedures that our residents, training doctors, are exposed to. And I think what a lot of people don't understand is that abortion care is more than just a termination procedure. With an abortion care, there are so many critical skills that are learned for young OBGYNs. This includes how to do an efficient office-based procedure, how to provide adequate anesthesia in an office setting, how to obtain informed consent and shared decision-making, how to be empathetic in some of the most challenging times in a person's life. And these are clinical experiences, clinical encounters that are very difficult to replicate in any other situation other than providing abortion services. Logistically, I have to send my residents now out of state to get the training that they need to be a comprehensive obstetrician gynecologist.
So that takes time and money too.
Absolutely. It has expanded our budget by upwards of $20,000 annually. And as a residency program director, my residents are like my kids. And if they're driving 2 hours to get the training that they need, I am worried when they're driving on the interstate. I am worried about their safety. And that's what keeps me up at night.
Sure. And also talk a little bit about, when we think about abortion, we think about, as you said, termination, but you need to have some of those skills in order to take care of pregnant women many times. So speak a little bit about that.
Absolutely. So our residents and most residencies will have experience in miscarriage management, but there is something very different for a second trimester termination procedure than a first trimester. The ability to manage bleeding from a uterus is critically important for obstetrics as well. There are going to be times in the middle of the night where a woman is hemorrhaging, and the skills needed to control that are skills that are often overlapping with abortion training. And so it has impact, I think, really throughout a woman's reproductive years.
Sure. And you talked also about the effect of OB deserts. Explain what that is and why that is.
Sure. So OB deserts are areas that don't have a labor and delivery or an obstetrician gynecologist kind of within their county. In Indiana, we have about 50% of our counties do not have labor and deliveries, just given the rural nature of our state. And there's many other states in our country with similar demographics of, one urban city, and then the rest of the state is really uncovered or untouched by healthcare. And obviously it extends beyond obstetrics. And if we are having restrictions, there are going to be less people willing to stay in a state where they can't practice the full scope of obstetrics gynecology and where they may be criminalized for practicing that. And so we're going to see a lot of these disparities increase. And so Indiana is number 3 for maternal mortality. And we're terrified of what that means for our future. And there's other states, particularly in the South and rural states with similar maternal mortality issues and the rural nature, which increases our obstetric deserts as well.
Really shows how legislation has so many broad implications. And Kim, kind of piggyback on what Nikki's saying with respect to workforce issues. I mean, talk about stress. And, we've already seen burnout prior to the pandemic. Pandemic did not help, especially with burnout statistics in the healthcare workforce. And in fact, it's been suggested that 1 in 5 physicians are intend to leave the practice of medicine in the next 2 years. And obviously, not only for physicians, but the majority of healthcare workers are women. But focusing on women and female providers, the American Medical Women Association, of which you're the past president, and Korn Ferry joined together to look at this issue and put together a guide that was called Women in Medicine, Setting the Agenda for Change. So what needs to change to help support women in medicine? Because the other point is that representation counts. And so I think we've seen a lot more focus on women's health because we've seen a lot more women in medicine.
Well, that's a great question. And we're seeing a lot of issues, as you said, with burnout, but the factors that are leading to burnout during and after the pandemic aren't any different than the factors that we saw pre-pandemic. And so this thought that we go back to the status quo really isn't sufficient. If we're going to affect change, now is the time for change. And that was, I think, part of the intent of the Korn Ferry report with AMWA. And so it's looking at things like understanding that even though a woman is a physician, there's still societal gendered expectations of her role outside of the home. She is still going to be doing the primary work at home. That became worse during the pandemic when childcare and elder care and school issues fell through. Women physicians are less likely than men physicians, are more likely than men physicians to be married to a partner or to have a partner who works full time. So there's not that leeway at home to have someone else pick up the slack. There is not the flexibility currently in how healthcare is designed for women to have the time and be given the time to take care of all of their responsibilities outside of work. We did some research on that here a few years ago, and one woman said, no matter where I was, I felt I needed to be somewhere else. That's a setup for burnout. But other things that contribute to burnout are experiencing harassment, conscious and unconscious biases, microaggressions. All of those can impact a woman's sense of belonging in medicine, feeling seen, heard, and valued. And in my mind, that's sort of the essence of burnout for women physicians. Do you feel like you belong in the workplace? Are you accepted? Are you given the things that you need to do to try to succeed? Or are you constantly trying to prove that you belong in the workforce? And so it's addressing those issues. It's making filing complaints of harassment very clear. It's making consequences clear. It's understanding what unconscious biases and microaggressions are, how to identify them, and how do we try to combat that. And I think most importantly, it's getting male leadership in medicine involved in this process. The vast majority of leadership in healthcare are men. This thought that things will change once we have more women leaders in medicine, I think it's a fallacy, because with the way healthcare is currently structured, we'll never have enough women in leadership to affect that kind of change. So it's getting the men in leadership now engaged in this process to help them understand the issues that women face and try to affect change now.
We're threading the needle with respect to policy and legislation. And you talked about burnout and mental health issues. And in fact, there was legislation that was passed that directly affected especially women in medicine, or really anybody in medicine. Speak a little bit to that as well, and any other policy implications you see for what you just spoke about.
The legislation that you mentioned is the Lorna Breen Healthcare Providers Act. That was pushed through the legislature, sponsored through the legislature with the Lorna Breen Heroes Foundation. That will provide funding for education, especially for those in training, to recognize the signs of burnout and help to address those. But other areas that we can address are things such as language on state medical licensure applications, hospital credentialing forms, insurance forms, forms that you fill out to undergo board certification examination. Those forms consistently have asked about whether or not a healthcare professional has a health condition that could impact their ability to practice. But not just currently. Most of the forms ask, have you ever had, or in the past 2 to 5 years, have you ever had a health condition? Have you ever sought treatment for a health condition? What we know is that for those states or those institutions that continue to ask those questions, healthcare professionals, especially physicians, are less likely to seek care. The goal of those questions was to help identify the people that needed care, but it actually ended up in exactly the opposite. And people didn't want to seek care because they were afraid of the consequences of reporting it. And so that's really a push now through AMWA and a variety of other organizations, is getting those questions off of the forms, making sure that physicians are competent to practice, to make sure they're getting the help that they need, but really focus on, rather than asking historically about any other health condition, are they currently impaired to practice? And if they're not, if they have a condition and they're seeking care and they're not impaired, then they should be licensed, credentialed, et cetera. And so that's really a push across the country now. How do we address these sort of intrusive questions, get rid of them, so that we can encourage all healthcare professionals to get the help that they need?
And that, has, I can see that reflected across the country in various industries as well, right? Karen, as a practicing cardiologist, do you want to add to what Kim just was saying?
I agree entirely. I think within cardiology, we're actually lower than surgery in the proportion of women in our field. So I very much heard and felt all of those comments. But, I do think that collectively valuing mental health and thinking about burnout, particularly not only for the physician community, but also for nursing and pharmacy and social work and all the other groups that take on the burden of caring for people in really tough times. We can't be good caregivers if we are in bad shape ourselves. And so normalizing these conversations and bringing all those groups to the table to talk about how to make better work environments, I think is really crucial.
And making a little bit of a connection with respect to mental health, we know that, for example, with pregnant women, postpartum depression is a huge issue. And mental health issues, again, across the board, we've seen it increased and a hotter light shown on that across the country. You work specifically with health equity and looking at different ways that we can approach that, especially with respect to insurance. And one way is through Medicaid. So explain what Medicaid is, why that's so important, and what is the impact of new legislation, if you will, not only on mental health with respect to pregnant women, but other issues.
Sure. So Medicaid is a series of state-sponsored, partially federally funded programs that are meant to provide insurance coverage for people living in poverty, as well as those with certain qualifying disabilities. And Medicaid provides funding for about half the births in the country and the majority of long-term nursing home care. So it impacts people absolutely across the lifespan, literally from birth to death. And provides a really crucial form of funding for some of the things where people just can't fund it themselves. Little kids can't work and get employer-sponsored insurance, and people who require long-term nursing home care are not eligible for employer-sponsored insurance. So it fills these really crucial life gaps, as well as providing a safety net for people who may be working for an employer who doesn't provide insurance or may be unable to work for various reasons. Medicaid is currently statutorily provided to pregnant women through pregnancy and 60 days postpartum, meaning that states are required to provide that coverage.
Now that's 2 months.
That is 2 months,
Right.
60 days.
So any of us who've had a kid, where were you 2 months after your pregnancy?
I didn't even really sit down. So 2 months, 60 days, and then states can end that coverage. During the public health emergency and then legislation that followed, states were encouraged to not remove people from Medicaid. And so we had women who hit that 60-day window and continued on during the public health emergency for COVID. And there's now been legislation passed to allow states to extend that coverage to a year. Now, I will take a quick sideline to say that I actually have a problem with Medicaid only being available for pregnant women. Like, women don't matter if they're not carrying a child. Like, that I think is inherently problematic. But I think we should take what we can get and also appreciate how crucial that extension of Medicaid is from 60 days to a year. So 60 days is not enough for the vulnerability of the postpartum period. And it's also when we start thinking about how to keep women healthy for the rest of their lives. We see diabetes, hypertension, heart disease, all either unmasked or elevated risk during pregnancy. And it really is an opportunity to link people to care, to get them engaged in chronic disease treatment, and provide a healthier, literally rest of their lives from a mental and physical standpoint. And cutting people off at 60 days is really no way to engender long-term health.
And I just want to make the point that Medicaid is determined by the states in terms of funding and what services are provided. And that is a policy decision, if you will.
That is a policy decision. States must meet certain terms in order to get federal funding, and the government picks up about 2/3 to 3/4 of the bill for Medicaid. So even though states administer it, they don't actually pay the majority of the funds, but they have a certain amount of leeway in what they provide. And so a number of states had chosen to expand Medicaid, many did not. And so this postpartum extension is a way to start to chip away at the real holes where people can fall through that net and have really disastrous and long-term health problems as a result.
Thank you. As I thought, this went really way too fast. And so I have so many more questions I wanted to ask you. But one question I will leave for all of you as an intro to our next conversation is the challenge of the fact that women's health research has not been funded adequately. And so I'm just going to go down the road and ask all three of you, how has that impacted on your clinical practice? So Nikki, I'll start with you.
It obviously directly impacts our clinical practice. The fact that pregnant people, aren't routinely included in drug studies, in vaccine trials. We can't then use that information to bring reassurance that the COVID vaccine is completely safe in pregnancy. So we are seeing more of that, but I would say, the COVID vaccine is a perfect example. And then when you think about our chronic diseases in gynecology, endometriosis, fibroids affect over 70% of the population, and we still don't have a really good treatment for it. And it's appalling to that we haven't made advancements in women's health. I trained in residency 15 years ago, and our management of fibroids is about the same.
Kim, how about your thoughts?
And I would reflect some on what Karen mentioned in terms of Medicaid expansion being for pregnant women only. And I think that's part of the issue when we're looking at women's health and women's health research is defining women's health by their reproductive system. Granted, that is a huge component of it, but it's also understanding that every health condition that can impact men and women demonstrates sex and gender-based differences. So there can be differences between men and women in terms of incidence, prevalence, presentation, risk factors in response to treatment. And so without understanding that then has an impact on research, because then studies that are looking at a common condition that impacts both men and women aren't necessarily designed to disaggregate the results based on sex and gender. They don't report the results based on sex and or gender because they see that this just impacts everyone, but not understanding that there are very different impacts between women and men, but if you don't look, you don't find. And so that can have an impact, first of all, not providing sex and gender data so we can inform the education of our future healthcare professionals, but it also directly impacts patient care. Without disaggregating data based on sex or gender, it's hard to take the results of a study and see whether or not it is actually appropriate to the patient that's sitting in front of you in the exam room. From my perspective, one of the big issues is pain. Women have more chronic pain conditions than do men. There are sex-based differences in how they perceive pain. There are gender-based issues on accessing pain treatment. There are sex-based differences in how you respond to opioids and the risks for addiction. Yet the vast majority of studies looking at pain do not take sex and gender into consideration, especially in terms of response to other interventions. So it's hard to know what to do with those studies, again, when you're looking at a given patient in your exam room.
Thank you. And Karen, I'll let you have the last word.
I agree with all of that. Beautifully said by both of my co-panelists. And, you know, in cardiovascular disease, we certainly understand that that is different in men and women, yet our research as to what to do about it is really lagging far, far behind. The basic sort of pharmacokinetics and pharmacodynamics of medications should be different in men and women. They have different body fat, they have different size. Yet we start everything with sort of our prototypical historical man in a clinical trial, 60-kilogram man in a clinical trial. So, you know, I think we have a long way to go. I think building communities like these is one important step to just talk about it and name it and get the people who are doing the funding to recognize that they need to make this a priority.
You beautiful segue. You just underlined getting the funding, which again is a policy decision. So thank you so much, all three of you, for your wisdom and your work. And I'll look forward to having longer conversations with you in the future. Thank you.
Thank you.
I'm going to bring on our next panel. Linda Greub is the co-founder and general partner of Avestria Ventures. Delphine O'Rourke is a partner in Goodwin's Women's Health and Wellness and Healthcare Practice, and is also an adjunct professor at Columbia Law School. And Sonia Sharma, is an associate professor at La Jolla Institute for Immunology. And I should say Dr. Sonia Sharma. So Sonia, I'm going to start with you because I think I teed it up for you with that last panel with respect to research. And, you know, we just heard that lack of research has really impacted on their clinical practice, lack of research on women's health. And I can't think of a better example than your work, where you identified a sex-based difference that could really have significant implications for how we practice medicine. So talk a little bit about your research with metabolites and cardiovascular health, and the significance of those findings potentially.
Absolutely, Mitzi. And you're absolutely right that I think the last panel discussion really supports what I'm going to say. And you're absolutely right that women-specific or female-specific or sex-specific research has historically been under funded. And, really, and this has impacted the way that we understand a lot of common chronic inflammatory diseases, such as cardiovascular disease, which is, of course, the #1 killer of women in this country, except before COVID, I should say. Our research has really, especially in the last few years, tried to focus on addressing this disparity in our understanding of the central premise that cardiovascular disease is different in women and in men. And it's a simple and fundamental concept, but really hasn't been translated at all into the clinical care, as you just said. And just to give you an example of that, failure to translate that biological reality is that, look at the funding. I mean, only about 4.5% of the more than $400 million that's committed yearly to studying coronary artery disease is focused on this disparity. And that translates to the way that these drugs are being developed, in the way that women are not actually equally represented in the clinical trials.
And can I just interrupt? I think that we just need to underline the fact that cardiovascular disease is the #1 killer of women. So it's not a small deal.
It's not a small deal at all. And again, one would think, just based on that metric and the simple fact that women, comprise an equal proportion of the population, that the research would be equal and the number of drugs, the drugs would be tested equally in women and men, but they're not yet there. And so what our lab has been trying to do is we study the immune system, and we know that the immune system has such a profound effect on basically, I would say, I don't think I'm exaggerating when I say it impacts almost every single disease, because blood, of course, innervates every single organ. And with CVD, it's increasingly recognized as an inflammatory immune disease. And what we know is that inflammation tends to be more robust in general in women. And this is likely because, goes back to pregnancy, because, when we're pregnant, we need that boost in the immune system to protect the developing fetus. And so what our lab has tried to do is focus on the molecular drivers, the metabolite, the metabolite drivers of inflammation, because inflammation and metabolism are really, really tightly interconnected, because immune cells have to proliferate, they have to grow, and they need energy. And so we've been trying to look at the specific differences in the immune drivers that drive more higher inflammation in females.
And you, again, found that there's a difference because you actually looked. And a lot of people don't ask that question or haven't, historically. And so obviously things have changed in the years. You heard an allusion to the fact that we've, for the most part, been doing research on 70-kilogram white men because they're easier to study, they're less expensive to study, and so forth. But in 1994, the NIH said, we're not doing that anymore. We're going to increase funding for women's health research only if, they're going to be funded, you have to include women and underrepresented people. But it wasn't until 2016 that they suggested that you include females in preclinical research, which means, female mice as well as the male mice, right? And so, all of those are policy decisions, correct? And
Yes.
where does who determines research funding and who determines those kinds of mandates?
That's a great question for folks to understand the process. Centrally, who is deciding, at least for the researchers, is the National Institutes of Health. And that's our federal body that funds through taxpayer money basic research and clinical research, into diseases. And the NIH, of course, these decisions come down from Congress. For example, the Revitalization Act that you mentioned in 1994 was signed into law by Bill Clinton. And so this is very much a government mandated policy that basically comes down to the researchers. And it's very important because, it's for so long, I think there was just a lack of knowledge, a lack of appreciation that these differences that you kind of eloquently said, there's a big difference between, in body physiology, in weight, in just general biology of, let's say, a 6 foot tall, 200-pound man and a woman. And then you add on other layers. We talked about pregnancy being a huge determinant, I think, of how our bodies have evolved over time and how our immune system's evolved. And so what I would say is that, the NIH, and I really want to be positive here, because we really did talk about that 1994 law, and there was another two which dealt with women and minorities in clinical trials. So they had to be included, and they could not be excluded just based on finances, which was the excuse that folks were giving. I think, it's too expensive to change what we already have. So they did that in 2016. The NIH mandated that also in basic research. We're talking about cells, we're talking about mice. And so these two kind of mandates have been very important, I think, in supporting researchers like myself, who now feel more empowered to study these sex differences. Whereas I will say before that, it was kind of this I don't want to say it was a dirty little secret, but it was something that you never wanted to get up and say, well, I'm studying something that's different in male and female mice. And it was kind of almost laughable at that time. Well, why are you studying something that's not inclusive? It must be an artifact, but it's not. I mean, you see that it's not. You see that in the disease disparity that we talked about for CVD. So that's the positive part. The negative part is that we're not there yet. And so I can't tell you that today every single clinical trial is equally enrolling.
Women. Well, it's a start. As you said, we'll try to be positive. But, from your kind of work to innovation, it's what seeds innovation. And that's where Delphine and Linda, come in. Delphine, as someone who works with these women's health companies, what do you think are the policy changes that need to to close that clinical research gap so that we can have more innovation.
And I'll layer on, so thank you for the question. I'll layer on to some of our sort of prior panelists who are not repeating. I mean, the issue of not reporting on the impacts of gender is huge. And as we touched on, you have the grant piece, but there's also, you know, what do all the pharmaceutical companies need to do? And that's where the FDA comes in. And not just having, and you know, let's recall in 1977, women were prohibited from participating in clinical trials. But it's, you know, FDA guidance and then enforcement and monitoring. Because there can be guidance, but if there isn't that follow-up like any other area, then you don't have data and, you know, you don't have the same incentives. So I would say, you know, really a requirement that the guidance, as the FDA likes to say, on the impacts of sex or gender. We are seeing more enrollment of women in clinical trials, but not early stages. You know, and I think it's also important to remember that, you know, in the administration, we have the presidential elections coming up in 2 years. The head of the FDA, the head of HHS, the head of NIH, generally changes with the administration. So it's important to think about what that impact will be, because they're both powerful policy making and grant making institutions. And I'll note on the, you know, on the amount of donations, you know, it's sort of, there were 2 announcements recently. One was a $3 million grant and the other was a $6 million grant in October timeframe, focused on reproductive rights, you know, that were applauded. I mean, the budget, I think, you know, don't quote me on the exact number, because I think it's like 1.7 trillion. So that is less than a drop in the bucket. So it's not just about getting, you know, yes, we need funding, but come on, $6 million, you know, so really pushing. And then again, as someone noted, it's Congress that's going to approve the budget. So when you're thinking about voting in 2 weeks, whoever you're voting for may be part of that process and saying, yes, it's great to have a budget, and then it needs to be approved. So really making it not discretionary, but a requirement that's then enforced.
Great point. Linda, do you want to add to that?
Well, I will say, to piggyback on Delphine's comment, you know, as much as the NIH can control who gets funding, which is incredibly important, when you look at what the FDA has been willing to approve, you know, remember, private companies are not relying on the NIH for their funding. You know, if we're talking about some of the large pharmaceutical companies, and there has been no requirement that their studies represent any particular type of population. Now, what our companies are seeing in going to the FDA now is that they are, when they're getting guidance about how they should structure their clinical trials, the FDA is pushing more on all types of, well, not all types, but more types of diversity, okay, in terms of what those private companies are presenting for approval. Yet, the last data I saw was 2015, still only 28% of trials are they analyzing the data by biological sex. So even if you were to include 50% of women in your trial, if you don't bother to analyze the results by the biological sex, it's pointless, right? So the FDA needs to ramp up its game, I think, on all of that. We're slowly seeing moves towards that. And there was a lot of excitement about a year ago about how many more women were in clinical trials and the FDA was approving more. But in fact, it just happened to be that in a given year, there were more approvals for women-specific drugs. So that was not indicative of a normal year, right? So let's not pat ourselves on the back yet. And absolutely, you know, coming from the world of venture capital, everything comes down to funding. Right? If you do not fund this early stage research into women, you will never see those innovations. And we've tried many times to split apart where the NIH funding actually goes. And the best we could do is we came up with maybe as high as 11% of the NIH funding was focused towards women's health. And we may be undercounting it because maybe we don't understand all the different ways to tease out the NIH. And then if you look at the private markets, at best, 4% of R&D dollars are being devoted towards women's health. And again, we define women's health as anything that impacts women exclusively. So that could be menopause, it could be ovarian cancer, it can be reproductive health in terms of labor and delivery, but it's also the diseases that predominantly impact women. So Alzheimer's disease, 2/3 of patients are women, and that's not because they live longer. Autoimmune disease, 80% of patients are women. And then, as Sonia brought up so well, cardiovascular disease is a disease that impacts men and women, but it impacts them differently, different prevalence, different symptoms. You know, women wind up in the emergency room and are so with a heart attack, and they're misdiagnosed. They're often sent home because they're quote unquote having a panic attack because they're not having the same symptoms a man is having. And we're learning that colorectal cancer, thyroid cancer, different presentation, different prevalence in men and women. And so, you know, women's health is not just about having babies. And we think that all of us need to start thinking about it that way.
Exactly. We just have a few minutes and I have so many other questions. I'm going to tee them up and then hopefully we can get to them. You talked about funding at the research level. You talked about funding at the, you know, the private area, private markets. And now let's take it a step further where you live, and that's investment. And so what are you seeing in terms of investment in women's health, and how can legislation or regulation help you with that? I'll stop there.
It's hard to see how legislation can help us other than the more funding that the NIH does towards women's health in terms of grants, that really supports a lot of our companies. So we can invest in an early stage startup, but that investment is being supplemented by grants. So grants really do matter. But you know, don't look to the Silicon Valley for big improvements in women's health. You know, as far as we can tell, so we know only 2%, less than 2% of venture capital dollars goes to female founders. When you look at venture capital funding for the life sciences, so healthcare, biology, less than 1% of all life science funding in venture capital goes towards women's health. So we're really not getting it in the Silicon Valley, right? And there are all, you know, there are all kinds of excuses about why, but I will say the entrepreneurs are getting it. You know, we do very early stage funding, and there are so many great innovators out there with great ideas, and yet the capital that is available to them from venture capitalists is minuscule. I mean, we're out there, and there's only a handful of other venture capitalists who are trying to fund innovations in women's health, and our dollars are just minuscule compared to the dollars that have gone to things like e-cigarettes, right? So you know, the overall capital markets have got to understand the opportunity and be willing to take the risks and move towards this sector.
And you know, when we do have those, you know, let's talk about ROI really quickly, because I want to talk about WHAM, because that was a good example of when any investor looks, they want the return on investment. And so this took that idea, and I'm going to ask Sonia just to briefly tell us what it is. And by investing a little bit in research, there were great returns. So can you tell us a little bit about that? And that's Women's Health Access Matters. And I want to give a shout out to Carol Lee, who founded that organization.
Absolutely. And you know, it goes with what Linda said, I think eloquently, is it goes back to the funding, it goes back to the dollars. WHAM, or Women's Health Access Matters, is a coalition that believes very strongly that women's health not only is primarily an economic issue. It's a societal issue, but an economic issue that we literally can't afford to ignore. And the premise is based on the fact that ignoring women's health has an enormous cost for the workforce, for the healthcare system that is just not being addressed. And just to give, just some, I think the most eloquent fact they have is from the WHAM report, which they commissioned. And this is a report that's basically examining the hardcore economics of the women's healthcare disparities. And what they've concluded in the WHAM report is that investing, for example, $300 million into women's health research would generate such a large restoration to the economy, a $13 billion benefit to the economy. And where does that come from? That comes from women who are more active and accessible to the workforce and less of a burden on our healthcare and our societal supports.
So it makes sense. Delphine, I think this is going to have to be maybe the last question, but so we have this research, we have the innovation, it's coming to market, and now it can't get promoted. Talk a little bit about that challenge and how you've seen it be dealt with.
Are you referring to censorship?
Yes.
Okay. So the challenge has been on social media that there are certain products, innovative products in the women's health space, or even sort of pretty standard products that are being censored by major social media platforms, think Facebook, for example, among others, so that certain words are being caught and images through their filters and policies. And you can look up, you can go to Google and look up their policy on what's permissible and being identified as pornographic or unacceptable. Spoke to a company where they said breastfeeding was dinged because it was considered, again, pornographic. So why is this a challenge? It's a challenge because it's limiting access to education for users of social media. I mean, if it's got guidance on lactation, on breastfeeding, that's an opportunity lost. It's harder for innovators if they can't get their products out there to the market through social media. We know it's a huge marketing platform, so their returns, their market entry is going to be limited. So it's not just a theoretical question. It's okay. So when investors are looking at investment in a startup, well, okay, what do your numbers look like? What are your sales? What's your engagement? Particularly, let's say mobile apps, where you're really looking at what is a user engagement over and over. If the companies are blocked from these social media platforms, that can be really prohibitive. Yet at the same time, when you look at their apps for let's say male products or advertisement for male specific products that are arguably a lot more provocative and sexy than any of these female products. So, it's been brought to, there's a great organization called the Center for Reproductive Justice, Jackie Rotman, great study on the issue. And the question is, how do you address it? These are private policies, but we're seeing a discrepancy in the enforcement. When I say the enforcement, and part of it is algorithms. So hopefully the companies themselves will recognize that they're doing sort of public disservice. If that,
and Meta just came out and said that they would be better.
They did. They just came out and said that they would be better. And I've heard, companies said, well, I'm not going to call it breastfeeding. I'm going to call it chest feeding. I mean, come on. I mean,
yeah. Well, and there was legislation introduced, I believe. Or
yeah, I mean, it's an issue.
So that's a place where, perhaps policy can help us.
Policy can help us in saying, you can't have gender discrimination. And one last point is, there's statistics that 40%, this is why the educational piece is so important, in addition to for innovators, 40% of people who sought abortion care use some type of contraception. So they were trying. So there's an opportunity for widespread education, community education, in addition to helping innovators, achieve market share. And again, it's a free speech. There's so many different angles to it that I hope that other platforms will follow.
Great. Well, that's going to have to be the last word. Again, I had so much more to talk to you about, but hopefully we'll do it another time. Thank you all for coming on today.
Thank you.
Hopefully we'll see you in the discussion session. Our next panel is going to look at social and environmental factors. We've got Joelle Abramowitz, Dr. Joelle Abramowitz, who's an economist at the University of Michigan, Linda Goler Blount, who's president and CEO of the Black Women's Health Imperative, and Dr. Regina Moss Davis, the Associate Executive Director of the American Public Health Association. Thank you all for being with me today.
Thanks for having me.
Sure. So Linda, the other way of thinking about this is what is, in the lingo, social determinants of health, or SDOH. And in fact, the AMA came out and said that voting is an SDOH, a social determinant of health. So what does that mean?
Yeah, and it really is. It's, social determinants of health are those many factors that actually impact our health and our health outcomes that have nothing to do with medical care delivery, or medicine. We've heard them all, things like access to healthy food, a safe neighborhood, housing, where you live, what kind of job you have, access to health insurance. I mean, there's many kinds of these factors, and depending on who you read, medical care is maybe 10 to 20% of what determines our health outcomes. It's not actual care and therapeutics. It's all of these other factors. And there's a historical context for them. These things are deeply rooted in policy. It's the policies that determine housing, redlining, for example. It's the policies that determine whether or not you're going to have a grocery store that serves healthy fruits and vegetables, or fresh fruits and vegetables. Your education system, what kind of education you have access to. That's a property tax issue. So the things that determine these social determinants are deeply rooted in history. You have to look at 400 years of oppression of Black people, more recently of brown people, immigration policies that determine what people have access to and what kind of choices they can make. And when we look at sort of the Black woman's experience, there's something called intersectionality, which means we can't actually tease these things apart. It's not just racism or gender discrimination. It's when these things come together and they are actually justice issues, which then gets us back to policy. And that's what determines all of this. And unfortunately, too often people look at the social determinants of health and say, well, it's just too complicated. There's just too much. There's nothing we can do. And so we don't actually see anything happen.
Well, hopefully we'll change that, especially with the folks on this panel. And in fact, Regina, that's what you do at the American Public Health Association, is look at a number of these factors. Though I do think that a lot of people, when they think of public health, think of diseases, like COVID. But what also COVID did, to Linda's point, is uncovered a lot of issues that have to do with the social determinants of health. So talk a little bit about what COVID did unmask, if you will, especially for women and women of color, and good and bad, and how does policy impact on those issues?
Sure. So women were, as we know, most likely to be exposed to the disease by the simple fact that we're overrepresented, or there's high representation of us in the essential frontline jobs like healthcare, education, the care industries, or the service sectors. But what we also saw was that stress was through the roof. It led to increases in depression, anxiety, and just declines in overall mental health, particularly among women who are primary caregivers or who are the breadwinners in the home. But we also saw that it was particularly acute for pregnant and postpartum women. We're starting to see the research, and studies are showing that women of color, low-income women, members of the LGBTQ community were more likely to experience pandemic-related health challenges. These communities are also historically less likely to have culturally competent mental health treatment, so there was an issue there. We also saw that COVID affected access and use to essential reproductive health supplies like contraceptives. And finally, that COVID really did reduce access and investments in the health, sexual and reproductive health care, maternal health care, but the other essential services that we need. So the study is showing that in the US, preventive screenings for breast and cervical cancer dropped 94% following the declaration of COVID in March of 2020. So while we are seeing the screening rates rebound, they remain significantly below pandemic levels. And so what we see is that despite these clear impacts on policy, policymakers still are largely failing to meet the specific needs of women. And so the policy implications continue to be what they were before, which is we need to eliminate barriers, we need more access to, and we need more investments in the care that we need.
And to that point, when you and I spoke, we talked a little bit about telehealth. So that may be the little bit of the bright star in all of this in terms of increasing access. Yet there's legislation, I don't even know where it is right now, even as a physician, when the pandemic started, for those who don't know, telehealth was allowed so that physicians and other care providers could actually provide care across state lines because we're licensed by the state, if you will, and that was a big deal. And also that improved, access when people couldn't get to absolutely couldn't get to the doctor, and especially with respect to behavioral health, and also paid for it, like an office visit, when a lot of physicians were really losing money just because they had to close their doors. So where are we now? And where do you think we should be?
Yeah, I'm glad you mentioned that because telemedicine was popular both for the providers and the patients, right? It eliminated the barriers to care for women in particular around transportation and childcare, but it was convenient and popular in terms of, being able to fill prescriptions. A lot of times you had to go into the office to do those kind of things, but also for those that don't live close, so it provided the remote access. I would say the polls are largely showing that people are satisfied with this type of interaction and that they want it to continue. And so that's what we hope the legislation will allow for that after the declaration. But there's also, we have to highlight the weak spots, which is that not everyone had the opportunity to access telemedicine. So older women, women with higher educational attainment, insured women, and women living in states that had expanded Medicaid were more likely to have telehealth visits during the pandemic than those that were not. So we really need the telemedicine legislation to continue. We need it to expand, to provide resources, especially for those that are that lack technological access, but those that live in low income or rural areas, or those with limited broadband. But also back to that point I made about the access to medication. So we need insurance companies to be encouraged to provide the reimbursement for 90-day rather than 30-day prescriptions, depending on the class of medication, of course. But we need to, again, try to eliminate the barriers so that people can live healthy lives.
Yeah, it's just something so small, it seems, makes such a big difference. And again, it's a policy decision. Joelle, Regina talked a little bit about, the impact of lockdown and the fact that people couldn't get preventive services and things like that. On the, before that, another shining star was the Affordable Care Act actually increased access to preventive services. So once, hopefully the lockdown and all of that has been lifted, women have more access if they are, have those, that kind of coverage. So what has the legislation like the ACA or Affordable Care Act meant for women's health, both in preventive services, but also with reproductive health care?
Yeah, so there have definitely been a number of different provisions of the ACA that have really enabled access to care, right? So some of the earlier provisions, enabling young adults to stay on their parents' health insurance up until age 26. That was important, expanding access or coverage for contraception, and certainly expansion of Medicaid. These were huge in, enabling better access to care. In my own research, I looked at the effect of the young adult provision on access to contraception and on abortions, right? And what I found there was that people were, young adults were able to get better care, and as a result, they were better able to utilize that care, right, in their contraceptive use to switch to more effective methods, which resulted in a decrease in the abortion rate.
I just want to underline more effective methods. So before that, less effective methods were covered, you could get access to birth control pills and things like that. But, things like long-term, like IUDs and all of that, not all of that, but more effective contraception. I just wanted to underline that. Just really quickly, I think we talked about this in one of the other panels. How are those coverage decisions made? Who makes those and at what level of government?
So really, and obviously the ACA was at the federal level, right? And that was really, I think a great aspect of the ACA is that, we could see, or the goal of it was that we would have this consistent, standard across the country. But we know that that's not actually how things work, right? There's also a lot of variation by state, and in particular with Medicaid, that states were able to opt out of implementing the Medicaid expansions. So we're seeing it both at those federal levels and at the state level. We also, in particular with health insurance, it's also related to employer-sponsored health insurance. And that can vary about state laws related to, what insurers are allowed to provide and employers are allowed to provide. So we're seeing, a lot of variation, and also on the locality level, right? There can be very specific laws related to your city about, different policies. And so, in that way, it's really important to think about all of your elected officials, right? And all of these policies, because it's not just at one level.
Sure. And one, glaring example is what's called the pink tax or the tampon tax. That can be city or state, correct?
That's right. And, where I live in Ann Arbor, Michigan, and I think it was the first state to, or not state, the first locality to require that private businesses provided free menstrual products, right, in restrooms. And so, that's something that's very specific to our locality. Other localities have done similar types of laws, but even, on a very small level, these can really vary. And it's something to be aware of when you're looking at, local ballot proposals and things like that.
Yeah. And Linda, you gave me a really startling statistic when it came. Why is that so important? Why is just something like, it sounds cute, a pink tax or a tampon tax, and it's not cute at all?
No, it really isn't cute, Mitzi. I think some people listening to this call might be shocked to learn that menstrual products are considered luxury items in certain states. I guarantee you, if you're a person who needs menstrual products, you don't think of them as luxury items at all. And so in some states, they're taxed at the level of luxury goods, like a Mercedes-Benz. And what we've found in our work working with high school students, young women in low resource schools, is that they are missing 1 to 2 days a month from school because they can't afford menstrual supplies. And that those 1 to 2 days a month are enough to derail their entire high school career. And so the officials here in Georgia and in the Atlanta public school system say that roughly 20 to 30% of the reason young girls don't graduate high school and then go on beyond that is because of the number of days they lose because of menstrual insecurity.
So just to add to that, because Joelle, you talked a little bit about this on the Aftershocks webinar, and just very briefly, you were one of the signatories on the amicus brief for the Dobbs versus Jackson in support of Jackson with respect to the effects of not being able to access abortion care and the economics of that. So can you quickly just summarize what that meant in terms of the economics? That again goes to Linda's point as well in terms of these issues really making a difference.
Absolutely. I think really the fundamental argument that that we were making in that brief was that, by not providing, these sorts of rights, then women don't have the full opportunity to participate in, the economic and social environment of our country. If they can't make decisions to decide about their education, their work trajectories, these sorts of things, then we will see effects, right, on their own educational attainment and, and work trajectories on that for their families, right, their communities, and for the economy overall.
Thank you. And that, again, the economy overall, it hurts everybody in the long run. And I thought that was very impactful. And then speaking of the workforce, Linda, talk a little bit about the Fair Work Initiative that Black Women's Health Imperative is focused on, and why that's so important, again, to everyone as well.
Yeah, it really is. A few years ago, we conducted a study and we asked Black women to sort of name the #1 health issue for them. And not surprisingly, it was stress. Dr. Davis Moss already alluded to it. Stress is the #1 issue. The workplace was the #1 source of that stress. And to put a finer point on that, we celebrate or acknowledge Women's Equal Pay Day every year. Well, this year, Equal Pay Day for Black women got pushed back 6 weeks. So it now takes an additional 6 weeks to earn what their white male counterparts earn. But because of the role of the workplace, we created Fair Work, which is a workplace initiative that looks at over 350 metrics to help employers understand what a fair workplace would look like and what the benefit is to them. We're moving well beyond the traditional DEI approach, because again, we've got about 25 years of literature and data that show that DEI hasn't really worked all that well, hasn't achieved its objectives. And that's because of the way it was crafted. Basically, it became white men's responsibility to do something to or for people who weren't white men in the workplace. And so everybody was aggrieved. So with Fair Work, we create strategies to get to fairness. And people may not know what equity is, but they know what fairness feels like. And we know if we can create a fair workplace, then employers reap the benefit. I mean, we can already draw a line to top and bottom line revenue and improved earnings per share and corporate performance. But importantly, it gives not only Black women, but all women data and strategies to make the best decision about where they might want to work or not want to work and what they can expect from that workplace. And if we can use the data that we get from this, which we will certainly try, to really push hard on equal pay, we know that the single greatest contributor to improving health outcomes for all women is just being paid what we should be paid for the work that we do.
It's that simple?
It's amazing how being able to afford things actually matters to your health. And so we're really excited about that. We've got 3 organizations with a total of over 100,000 employees who are going to start with us out of the gate. And so stay tuned and look for the results, because I think it'll be really informative.
Terrific. Thank you. And we are always running out of time. Regina, before I leave you, I just wanted, you had one thing I wanted to talk about. So I'll put this out there because I want to get your all of your thoughts, but also I want to also ask Regina this one question as well. You talked a little bit about things I didn't really think about when I thought about women's health and legislation. So very briefly, migration and the built environment.
Or, well, I'm trying to do that briefly, but
I know it should take at least a whole day, right?
Yes, talk about it in the context of climate change, which is basically that it's no longer, I'm glad that people aren't looking at it just as polar bears, but it really does increase women's health risks, and it really does compound our pre-existing vulnerabilities. But I talked about it both in a domestic and a global perspective. And so from a global perspective, climate change will produce an estimated 200 million global refugees. And so when natural resources become scarce due to climate change, girls and women are going to travel to find secure water, food, and whatever else they need. And so that increases their risks for sexual abuse, gender-based violence, disruption in sexual and reproductive health services, and more. Happy to talk more about it, but that's one aspect of it. And just, of course, there's environmental exposures, increased risk for things like low birth weight, preterm birth, when you have when you're exposed to things like extreme heat and particulate matter.
And then you talked about, again, environmental issues like not having access to clean water, for example. But going to your point, thank you for the segue. And this is my last question for you all. I can't leave this conversation without talking about maternal mortality. We've alluded to it a little bit in some of the other panels, but it's a travesty that in the United States, it has one of the worst mortality rates for pregnant women than in any other developed country. And we know that Black women are 5 times more likely to die. What I also read yesterday was that the number one cause of death in pregnant women is murder. And it was a study in the British Medical Journal. If you have that information, but we know that violence against pregnant women is a significant issue. So if you can, paint what you would like to see happen in this next legislative session to make those numbers better, what would it be? And Regina, I'll start with you.
I mean, we need to stop committing violent acts against women, that in and of itself, but that has to do with power, gender, and the value of how we are perceived in society. I'm going to just touch a little bit on the policy piece of this, and just to give the space for my colleagues who may want to answer this, but it was certainly, we saw increases during COVID. Anytime we have issues around poor coping strategies, those are associated with various forms of gender violence. There has been the reauthorization of the Violence Against Women's Act, which has been critical in providing services to survivors. We need to continue to do things like block grants to those critical organizations that are providing services around sexual assault. They can help with the legal help, but they can also help navigate the system. I do know that the United States, at the Generation Equality Forum, had made some commitments around preventing and responding to gender-based violence. The American Rescue Plan creates a safe leave for gender-based violence survivors. So these are women who are fleeing domestic and intimate partner situations, but we need to do more in this space. And it really does start with how we value women.
Absolutely. Joelle, do you have anything to add?
I would certainly echo what Regina just said. I'll add, focusing on the piece about maternal mortality more broadly and how we should think about that going forward. One thing that's always struck me on more of the research side is that we don't have great data about maternal mortality. There are issues about how it's collected, if it's been consistent over time or consistent across states. And it makes it really hard if we don't have the data to be able to understand, what are different drivers and how do we address them and how do we implement policies. So I would, emphasize that we need to start there to really think about some good evidence-based policies that we can implement.
Thank you. Linda.
Yeah, and I certainly echo my colleagues. What we see is also a symptom of the fractured society that we live in, of incarceration policies that started with the Reagan administration, and what happens when you have policies that put men in jail, and then when they get out, they can't vote, they can't be employed, and there are no supports in place. And to Dr. Abramowitz's point, maternal mortality review committees don't exist in every state. They don't collect the same kind of data. They don't have the same composition. So even with the data that we have, we're not making good decisions, but we don't actually have enough data to fully understand what is going on. But if we do know that if everyone had a living wage job, that would go a long way to eliminating violence of all levels, and particularly violence against women. And if women had equal pay, I'm going to come back to that, then we could get ourselves out of those kinds of situations. But women make choices that make perfect sense to stay because they have to, and it's understandable, but we need to change society so that we don't have to make those very difficult decisions.
We'll have to let that be the last word for this panel. Thank you all so much, and hope to have another conversation, a longer one, another time. So thank you very much for being with us.
Thank you.
Thank you.
So our next panel is the action part of this webinar about voting and advocacy. We've got Dr. Heather Carter, who's an executive vice president of the Greater Phoenix Leadership and a former state senator and representative in Arizona. Linda Goler Blount is coming back for a second panel. And also Liz Powell, who is the founder of G2G Consulting and a policy consultant for the Women's Health Innovation Coalition. So ladies, now we've heard about all the issues that we need to deal with. So how do we deal with them? Heather, I'm going to start with you because again, I think we've touched on the issues about why it's not just the federal, but it's also state and local and school board. So put a fine point on that. Tell us why it's so important to vote down the ballot.
Thank you, Mitzi, once again for having me on this panel. And today I hope is a day of action. Everyone on this call needs to make sure they vote in whatever state they may reside. In Arizona, you must mail your ballot back in by November 1st. And we are requesting that you vote from the top of the ticket all the way down to the bottom of the ticket, and maybe even flip your ballot over and the entire backside of your ballot. I get it. These ballots are long, but here's why it's so important to vote in down ballot races. What we find, especially when we're talking to voters, is many people watch their evening news or follow social media, and they get really fired up about things that are happening at the federal level, or perhaps not happening at the federal level. But when you're talking about healthcare specifically, so many decisions are made in the state legislature. Those bills are passed by the legislative body and then either signed into law or vetoed by the governor. Especially when it comes to physicians, licensing, scope of practice, everything from how you were paid, when you were paid, the process for providing care, all of that is governed at the state level by your local health boards and your licensing boards. So while we're having this really robust debate about national politics, you've got to bring that down to your state. And now, even as we've watched over the last 2 years, these decisions have come to the county level. When you look at your county boards, you can look at that from a health perspective, from a public health perspective lens. And what we're seeing play out even more directly impacting at the local level, even in the school board races. So these races typically don't receive as much attention on the evening news. There's not a lot of money that's put behind these races. Maybe at the state level, it might be $1 or $2 million, which sounds like a lot of money. But when you're looking at these federal races, they can be in the tens and hundreds of millions of dollars. It is really important for women in this election to pay attention to what people are saying in all of these races, because when you least expect it, you will find these women health issues popping up in all of the races.
Can you give an example?
More than ever to get involved.
Absolutely. Can you give an example? I mean, we've seen how Medicaid is determined by the states, certainly abortion care and access. Any other things that we might, and we even talked about the tampon tax, you know, at the municipal level. Any other things that you think might surprise us?
Well, I think those are key issues. And the challenge becomes, when you look at party politics, it's basically duality of either one way or the other way, black and white, right? And that's not what is reality when you are faced with these challenges in the exam room, at home, trying to put food on the table, trying to meet your own individual personal women healthcare needs. And so you need to find candidates who are willing to have these really deep, important conversations around not only what the top of the ballot says, not only what the top of the bill says, but really what are those unintended consequences. This is the second webinar I've participated on that you've hosted that really takes a deep dive into some of these issues that don't get talked about at the dinner table. But yet, when your family is facing these at the 11th hour of a health crisis, you realize that this decision was made, and now your healthcare is out of your own hands because a politician has made a decision. So this election, I think more so than any of the last 10 years. I've been involved now either running for office or advising candidates running for office in the last 2 years. More than anything I've seen in the last 10 to 12 years, women's healthcare is on the ballot. And that's the title of this
Sure.
webinar.
Thank you. And I just also want to underline our previous conversation, Linda, that you put on to Heather's point. It's not just those obvious healthcare issues, but those other things like fair wages and other of those, what we now call social determinants of health. All right, ladies. So what do we need to know about voting? Liz, I'll start with you. Just take us through what people need to know to make sure that their vote counts.
Yeah, thank you so much. I mean, I just echo everything that Heather was just saying. There are so many issues at stake. And what's really important is to talk and engage with folks when they're running for office so that they understand women's health is a top priority for you. Whether you're a Democrat, Republican, Independent, does not matter. This is a way above party. So they need to understand that on the campaign trail. And then once they're elected, you need to follow up and work with them. And again, it does not matter what political party. What I have found over the years, these women's health issues, they are of interest to all. You just have to hit them repeatedly with the same message to educate over and over again on that and the importance of that, and then turn that into what they can do. What's a bill they could co-sponsor? What's an agency they could call over and influence? What's a question they could raise during a hearing? What's a funding level they should include in an appropriations bill? So that's more of the detailed tactics, but the key is just engaging and making sure that they know why these issues are important and that you're going to consider that when you cast your vote. And the community in which you work in is also going to do that. And then as far as voting, there's still time to vote. I have my own voting by mail, which I do regularly because I'm always too busy to vote on election day.
You're in what state? You're in Ohio, right?
No, I'm Virginia, actually.
Oh, Virginia. Okay.
Yeah. So there's lots of ways to vote. You can vote early. You can vote by mail. But it is really, really critical that you vote no matter how busy you are. I get it. We're all busy, but you've got to vote and you've got to tell your friends to vote. So
that's exactly
really
right.
important. Yeah.
And Linda, to Liz's point about the education, the BWHI has a voter's guide. You want to talk a little bit about that?
Yeah, thank you, Mitzi. This is our third voter's guide. It's called Black Women Vote, where we highlight key legislative issues for Black women's health. And we talk about what they are, what they mean for Black women's health, what sort of the implications are of these legislative, the laws, proposed legislation, what's been passed, what hasn't, and what it means to Black women. So our third edition is out. It's on our website. You can go to bwhi.org and download it. Not surprisingly, it's focused significantly on reproductive rights and justice this year, but it's a way of helping women understand what the key issues are, as we've just heard.
And men can understand.
And voters understand.
But there you go.
Given that we are nonpartisan, we developed this guide as well as a scorecard that Get Out the Vote organizations can use in their work so their constituents can literally mark where the candidates are on the issues and then make their decisions accordingly. So we are giving them the tools and resources we hope to make the best possible decision for people who are concerned about women's health.
Thank you. Heather, in the chat, you said you wanted to respond to something that Dr. Yen said, which is basically bring friends.
Yes, thank you so much. In the chat, it was mentioned to bring 5 friends. And that sounds so simple, but it's really, really difficult. We're facing a time in our country where people don't want to talk about politics in their family, at neighborhood events, over the holidays. And guess what? If we don't talk to our friends and families and neighbors about these issues, who will? And so it is so important for you to take action after this webinar and start that conversation. Don't laugh at me, but I was in the grocery store yesterday and checking out, and somebody mentioned the price of gas went down. So I said immediately, well, make sure you vote. And then she says, well, I'm going to vote on election day. That's great. That's a start. But when you're talking to your friends, and Liz, maybe you and I can go a little bit into this, make a voting plan, because what happens on election day, if you wait until you vote on election day, life happens. It could be raining, your car could break down, somebody could be sick, and you've missed your chance. One of the most impactful things we've seen in research about engaging voters is to, number one, have a voting plan. Research your locations, research the hours, make a plan to vote. I would argue make a plan to vote early, and then follow up with them and make sure they have voted. I will tell you a little story. A friend of mine here in Arizona was running for an office. I won't say name, I won't say what office, but it was way down the ballot. He lost by 2 votes. I know 4 people in the area he was running that didn't vote, and he lost by 2 votes. So when we're looking at these elections, we have a congressman in Arizona who won his first election by 27 votes. And he's making decisions in Arizona for women's health care. 27 votes. Every woman on this call, every man on this call that cares about these issues actually ensured that 5 people came out to vote that are in support of what we're talking about today. We can make a difference across the country. And last pitch, this is a mid-cycle election. This is not a time, there's not a presidential election on the ballot. So voters that pay attention every 4 years, sometimes they take a pass on these mid-cycle elections. This is not a year to take a pass. If you take a pass during the 2020 election, I cannot guarantee what will happen in the 2024 election. We're not even talking about threats to democracy in the elections, but all of that is on the ballot as well.
Thank you. And Liz, just remind us what's in the balance here. We could see a whole different group of legislators.
And I just want to echo how critical it is, the vote. Like, most people don't realize in 1800, Thomas Jefferson was elected president by 1 vote in the House of Representatives. So many particularly state houses, there's like countless examples of like 1 to 10 votes literally decided. And in Virginia, locally in 2017, we had a delegate who won by 1 vote. The court threw it out and ended up doing a drawing, and then the other person won. So, I mean, there's just so many, even in the US Senate, Franken won in 2008 by 312 votes. So it's your vote really matters. So just want to emphasize that. And back to your question, what's at stake? So what's interesting is that the way the Congress, the House in particular, flips every few years, it seems to flip. And it's looking like right now that the Democrats control the House, the Senate, and the White House. And it looks like the House will flip to Republican control. How much is still in question. And if it's just a few seats, boy, is that tricky. That's a really hard chamber to run. If it's 20, 30, 40 seats, then it makes it easier to run. The Senate is a total question mark. It is split right now. The only reason Democrats control it is because they have the Vice President Harris, that is the deciding vote that gives them that 51. But the Senate is a big question mark. And so we don't know what's really going to happen. The point of that, though, and it literally flips. I mean, remember when Trump won, it was a huge tidal wave, and it was the House, Senate, and the White House, first time in many years. The important thing to take away from that is that we have to work with everyone, right? We have to work with Democrats, Republicans, and independents. And there is a common sense approach. We all know it, or we wouldn't be on this call today, right? So we've got to make sure that we maintain that ability to work with as many folks as possible. I will say, though, the way the system is set now and they're redistricting, it is rigged for the most extreme to win primaries, which makes it very difficult once it gets into Congress or state houses, et cetera. But despite that, we're not going to give up. We have to keep talking about women's health, because literally everyone has a mom, right? You've got sisters, you've got nieces, right? So there's always a way to talk about women's health. So I just want to make sure I said that as well.
Thank you. And we are out of time. We're actually over time, but I'm going to refer folks to the podcast that I did with you, shameless plug, but you talk a lot about advocacy after the election and how you can make or have your voice heard with your representatives. So we didn't get a chance to talk about that, but I want to underline that. Ladies, thank you again. And hopefully we'll we not only changed minds, but maybe inspired a few. So thank you so much for joining me.
Thank you.
All right. So we're going to end, and I apologize for being a little bit over. I want to thank everyone for joining us today, and I especially want to thank all of our incredible panelists. But as you heard, November 8th is Election Day, and there's still time to make your voice heard. Don't worry about those polls. Just go and vote. Have your voice heard. I have a necklace that says, you had the power all along. If anybody remembers, that's Glinda talking to Dorothy from The Wizard of Oz. We have the power in our vote. Vote. And as everyone says, bring a friend, vote in a vote party. Somebody had suggested that in the chat. Whatever you do, again, these races may come down to very small margins. I also want to invite you to check out our resources at Beyond the Paper Gown. We'll have those. It's a growing document. We'll also have a downloadable Women's Health on the Ballot checklist to use when evaluating your candidates. And I just, again, hope to see you in the discussion. Please do join us. And I hope to see you at the polls. Thanks so much.